Good evening. We are starting a new series on mechanical ventilation, and today in this first lecture we will be talking about the basic concepts of ventilation, in which we will read about some terminologies which we'll try to remember also. So we start with volumes. We all know this graph wherein we have tidal volume, then we have inspiratory reserve volume, we have expiratory reserve volume, and we have tidal volume. So what do we mean by tidal volume? In tidal volume, there is no effort. It's an effortless process of taking in air and expirating out without any effort. So this is what is tidal volume. When you inspire after taking tidal volume, this is known as inspiratory reserve volume. This part is inspiratory reserve volume. When you expire fully after your tidal volume, this is your expiratory reserve volume. And what remains after expiratory reserve volume is residual volume. So these are volumes, 4 volumes. We have tidal volume, we have inspiratory reserve volume, we have expiratory reserve volume, and we have residual volume. Now there is something known as capacities. So tidal volume plus inspiratory reserve volume is inspiratory capacity, right? Similarly, expiratory reserve volume plus residual volume. Expiratory reserve volume plus residual volume is functional residual capacity, FRC. This is very important. Functional residual capacity. This is the equilibrium point at which your chest wall pressure and your pleural pressure equalizes, right? So this functional residual capacity is a very important point. You have equalization of pressures here. We can measure all capacities and all volumes, but we will not be able to measure the residual volume by spirometry. For measurement of residual volume, we need to have body plethysmography, which is not readily available. So for research purpose only you measure residual volume, otherwise inspiratory reserve volume, tidal volume, expiratory reserve volume, inspiratory capacity and functional residual capacity are sufficient. All volumes, if combined together, becomes to total lung capacity, TLC. Once we have an idea about volumes and capacities, we can try to learn something about dead space. What is dead space? This term is often used when we talk of respiratory physiology. Dead space is that volume of air in airways or lungs which do not take part in respiration. So dead space is volume of air in airways or lungs which do not take part in respiration. It is of two types: anatomical and physiological. Anatomical dead space is that volume of air which is there in trachea, bronchi and bronchioles which are not lined by respiratory epithelium. So gas exchange doesn't take place. So anatomical is that. Physiological is anatomical plus that air which is there in alveoli which are not perfused but ventilated. So there are certain percentage of alveoli which are ventilated but not perfused. So you add anatomical dead space and that alveolar space which is not perfused, that becomes physiological dead space. Physiological dead space can be calculated by an equation known as Bohr's equation. The equation is Bohr's equation. for physiological dead space. So what is Bohr's equation? It is dead space is equal to, you have tidal volume, you multiply it by P arterial pressure of CO2, you subtract partial pressure of CO2 in expiratory air, and you divide by PaCO2. So by this Bohr's equation, you can calculate the physiological dead space. This is tidal volume, this is partial pressure of carbon dioxide in artery, this is partial pressure of carbon dioxide in expired air divided by partial pressure of carbon dioxide in your artery. After dead space, you have ventilation rates. In ventilation rates, again you have two things. One is known as minute ventilation. You must have heard this term in your ICUs, minute ventilation. It is denoted by a symbol V with a point above it. When we put a dot over a symbol, it means it is denoting the change of that variable with time, or it's a rate of change, right? So this is your minute ventilation. So minute ventilation is tidal volume into your respiratory rate. This is your minute ventilation. Okay. The more appropriate ventilation rate for understanding purposes, alveolar ventilation, VA. That was minute ventilation. Now you have alveolar ventilation. So how can we calculate alveolar ventilation? Suppose you have tidal volume and you minus your physiological dead space. You minus your physiological, that physiological dead space is not taking part in active respiration. So you minus that physiological dead space and you multiply it by respiratory rate. So this becomes your alveolar ventilation, right? So you have minute ventilation, you have your alveolar ventilation. This is more appropriate and more physiological term to be remembered. The next concept is lung compliance. Lung compliance. So what does it mean by when we say lung compliance? It means that you have a change in pressure and you have a change in volume, right? So either you can write volume or change in pressure. So if you change the volume, the pressure changes, and if you change the pressure, the volume changes. This is known as compliance. The rate, when you have differentiation between rates of change of pressure and volume, this is known as lung compliance. So it can be, you know, graphically represented. You can graphically represent as, this is volume, this is your transpulmonary pressure. You understand transpulmonary pressure? Transpulmonary pressure is, suppose this is an alveoli, this is your pleura, and this is your atmosphere. So this is your P atmosphere. Suppose it is 0 at rest or for convention. This is your alveolar pressure, P alveoli. It is also 0. There is -5 centimeters of water of intrapleural pressure. So difference of alveolar and intrapleural pressure is known as transpulmonary pressure. So difference of alveolar pressure and intrapleural pressure is your transpulmonary pressure. So you can, if you plot a graph of volume versus transpulmonary pressure, we can get lung compliance. So just imagine that you have this point as functional residual capacity. So this is an equilibrium point. Okay, so no gas exchange is taking place. Now diaphragm contracts, so there will be increase in transpulmonary pressure and volume increases, the lung volume increases. And then you have passive expiration, so it goes down like this. So this is inspiration, this is expiration. Conventionally, our mind says that this line, expiratory line, should follow the inspiratory line, right? But it is not so. Why? Because when you inspire, you need more force for alveolar opening, right? In expiration, you don't require alveolar recruitment or opening. So that is why there is a difference, and this difference between these two lines is known as hysteresis. The difference between these two lines of inspiratory line and expiratory line is hysteresis. So when you want to know the lung compliance, so the slope of the curve gives you lung compliance. So lung compliance is changing, it's dynamic, it's not static. As you inspire, the compliance changes. As you expire, the compliance changes. So you can have multiple compliances. So you have the slope of the curve which gives you lung compliance. So we'll just see an example. Say, suppose this is transpulmonary pressure, this is volume, this is functional residual capacity, right? And for simplification, we are using this expiratory curve only. So this is normal. Now suppose there is a patient who has fibrosis lung. So a fibrotic lung has poor compliance, it's a stiff lung. So obviously the functional residual capacity will decrease, right? And as you inspire, as compliance is less, the slope of the graph will be less steeper. So this is in pulmonary fibrosis. So we all know that pulmonary fibrosis patient, respiration takes place at low lung volumes. So total lung volume is less, and this is the reason that functional residual capacity decreases and the graph is less steeper. So it's a poorly compliant lung. Suppose patient has COPD. A COPD lung is more compliant, there is more volume, so the functional residual capacity increases and graph becomes more steeper. A COPD lung is more compliant, right? So this is the difference when you plot graphs of various disease pattern of lung. Okay. Then you have a last concept to understand is airway resistance. Airway resistance. You know, airflow tube, airflow is inversely proportional to resistance. The higher the resistance, the lesser the flow. It is inversely proportional to the resistance and it is directly proportional to pressure gradient. The higher the gradient, the faster will be the flow. So this is pressure gradient. This is resistance. And from our physics class, we remember that resistance in any tube or tubular structure is inversely proportional to the fourth power of the radius. right? So tiniest changes or minutest changes in the caliber of a tube can affect the resistance in 4 times magnitude. Okay. So when we think of lungs, again, if we apply this concept of resistance, that smaller the airway, the higher the resistance. So terminal bronchioles, which are more in number and which are minutest in their diameter, should offer most resistance, but that's not the case. What happens is, in terminal bronchioles, when you cut the lung and when you examine it in the cross section, so though the diameter is less, but the total diameter of the terminal bronchioles will become more. So in total, the airflow resistance is less. So the most airflow resistance which comes is medium sized bronchioles. So if you are talking of bronchial asthma, we are talking about medium sized bronchioles, we are not talking of small bronchioles. Similarly, airway resistance can be affected by autonomic nervous system. Means sympathetic drive will decrease resistance and increase flow. Parasympathetic will increase resistance and decrease flow. Suppose lung volume is more. So what will happen? There will be stretching of the airways. So if you have high lung volumes, so you have increased flow. Suppose you are ventilating a patient and inadvertently you have increased the lung volume, so the flow also increases because the resistance has decreased. Similarly, if the lung volume is less, there is decreased flow. Okay. So the basic concepts are volumes, then you have capacities, then you have dead space, then you have ventilation rates, then you have transpulmonary pressure, then you have lung compliance, and then you have airway resistance. So this is must to understand the finer concepts of mechanical ventilation. So what is mechanical ventilation? The definition of mechanical ventilation could be that you either assist or you replace normal respiration process. Either you are assisting or you are replacing totally the normal ventilation or normal respiration. So why do you need mechanical ventilation? You can need mechanical ventilation in case of you have hypoxic respiratory failure. Suppose you have ARDS and you have hypoxia despite giving oxygen, so you need ventilation. Now this ventilation could be an assisted ventilation in the form of non-invasive ventilation, or it could be an invasive ventilation depending upon the clinical scenario. So the first indication of any assisted or total mechanical ventilation is hypoxic respiratory failure. Second could be assisted respiration is mandatory in some cases. Say for example, you have abdominal surgery. So you assist. There is no pathology in the lung, but you are assisting by giving a non-invasive ventilation, right? Or you have a CO2 retention in COPD. So you are again assisting, you are not replacing. So this could be one. Third, prevention of aspiration. Say you have head trauma and patient is comatose, so you can aspirate. So you have to do ventilation in these patients. Mechanical ventilation is mandatory. Fourth, suppose you have upper airway obstruction. Someone comes with anaphylaxis, severe angioedema. So you have to do mechanical ventilation in case of severe upper airway obstruction. Right? So physiologically, there are two types of mechanical ventilation. One is negative pressure, which we don't use nowadays, ventilation, and the second is positive pressure ventilation, which is used in acute medicine. What is negative pressure ventilation? Negative pressure ventilation means that in the extrathoracic space you are applying negative pressure, right? And in positive pressure ventilation you are applying positive pressure, airway pressure in the extrathoracic space. So this is the difference. Negative pressure ventilation was used in early 40s, 50s when there was epidemic of polio, right? So there were large containers in which the whole body was kept, and the container delivered negative extrapulmonary pressure, and by that your lungs were, expanding. So if we go into slight details of negative pressure ventilation, just to understand the physiology. Suppose this is your alveoli, this is your pleural space, this is the chamber in which person is lying. Okay. So this is extrathoracic space. Suppose the pressure is 0 at rest. Alveolar pressure is also 0. This is minus 5 centimeters of water. Physiologically, the pleura or the lung has a tendency to collapse inwards, and the chest wall has a tendency to collapse outwards. That gives you a negative pressure difference, though the pressure is 0, 0 at alveoli and atmosphere also. So you have negative pressure in the pleura. And because of this negative gradient, you have transpulmonary pressure which drives air in and out. Suppose you switched on the negative pressure ventilation and you fix the pressure as minus 10. You apply minus 10 centimeters of water of pressure in the extrathoracic space. So there will be a pull. There will be a pull in this direction. This pull will be transmitted here also. So there will be a pull. So there will be some negative pressure created in the alveoli. Mind you, this pressure and this pressure won't equalize because pleura has a tendency to collapse inward. So this pleural pressure of collapsing inwards will try to balance out this pressure. So that is the reason that intra-alveolar pressure is less, always less when you apply a negative extrathoracic pressure. Now when you have negative intra-alveolar pressure, the atmospheric pressure is 0, air will come in. As air will come in, the volume of the alveoli will increase. The volume of alveoli will increase and it will become bigger, right? So gradually what will happen is this pressure becomes 0. Getting the point? As air has rushed in, the pressure becomes 0. It's equalized. Then you remove this pressure, make it 0 again. So because of its collapsing property, see, when the lungs are compliant, so the collapsing property increases. If your lungs are stretched, they will try to collapse. So there is a natural collapsing and giving rise to expiration. The air will move out. Okay, we can plot a graph of negative pressure ventilation. This is 0, this is minus 10. It's plus 10. Zero is atmospheric pressure, P atmospheric. Minus 10 is what you have delivered by ventilation. So what will happen? As you initiate the pressure, the alveolar pressure decreased. It will go down. Gradually air will be filled up. When you stop it, it goes like this. So this is your inspiratory cycle. Inspiratory cycle. Right? When you remove this pressure, there will be expiration. So there will be expiration like this. This completes your one cycle. It's a bit difficult to make a picture in mind and understand it, but in a negative pressure ventilation, you are applying pressure in the extrathoracic space, right? You are not using it, but just to understand the physiology, it is fine to understand the basic nuisance of negative pressure ventilation. So the graph will be like this, a sine shaped graph. Now what happens in positive pressure ventilation? You are not applying pressure in the extrathoracic space. You are utilizing endotracheal tube, which is there in the lung, and there is a tight seal. This is your pleural space. So outside pressure is 0, inside pressure is 0, here it is -5. Now you apply a positive pressure through the tubing. So I apply plus 10 centimeters of water. So obviously there is a pressure gradient now, plus 10 and 0. Air will rush in through the endotracheal tube. It starts stretching. The pressure increases. As pressure reaches plus 10, flow ceases. Flow will cease. There is no pressure gradient now. Then you stop applying the pressure there. Again make it 0. So what will happen? This air will rush out. So here the pressure gradient of the ventilator and the lung is driving air in and out. If you plot a graph of positive pressure ventilation, it will be something like this. This is your plus 10, this is your 0. So as you apply pressure of plus 10, the lung volume will start increasing like this. Start increasing, it will go, it will reach plus 10. Right? So this is your inspiration. Inspiratory cycle. Then you withdraw the pressure from outside. Then you have withdrawn the pressure. It will drop. This is your expiration. In your ventilators in ICU, you will definitely see these type of graphs, right? The next inspiratory cycle will come. A slope and then collapse like this. So this is your positive pressure ventilation. So what is the benefit of negative pressure ventilation? See, the benefit is that it is non-invasive. Negative pressure ventilation is non-invasive. Person can eat and he can talk. Obviously there is no endotracheal tube. There is less chance of aspiration. Less chance of aspiration. And you don't require any sedation. No sedation is required. Right? So technically, This can be used where you have diaphragmatic failure and your lungs and airways are good. Patient is fully conscious, awake. So there you can have application of negative pressure ventilation. What benefits are there from positive pressure ventilation? This is more, you can individualize the treatment. Right? You can deliver high FiO2. You can fix pressure gradients. You can increase the gradient. In negative pressure, you can't. You have a fixed gradient. So you can have different gradients as per your requirement. So high gradient can be generated or low gradient can be generated. Then it can be safely used in unconscious patient. Okay. So you have benefits of negative pressure ventilation, but it is not used technically in acute medicine nowadays. It was used in 1940s, but just to understand the concept, it's fine to know a bit about negative pressure ventilation. From henceforth, we'll be talking only about positive pressure ventilation in further lectures. Thank you.